Welcome to the OCOM podcast, Modern Medical Education, where we bring experts each episode to discuss the modern aspects of medical education and medicine in general. My name is Dr. Robert Hasty, the host of the OCOM podcast, and today we are talking about the future of radiology. I'm here with our good friend, our clinical faculty member, someone that I've known, I've been friends with, and heck, we talk for probably close to a decade at Nova Southeastern. It's our good friend, Dr. Jordan Ditchek, radiologist extraordinaire.
Thank you. Thanks. Great to be here.
Great. Yeah. And we were just talking about right before the podcast about 20 years ago. I was like this young, newly minted assistant professor at Nova Southeastern. I inherited the radiology course. And I'm an internist. What do I know about radiology? So I said, I need to get somebody that knows their stuff. So I called my friend Dr. Ditchek, and we took over the course. And it was the highest rated course at Nova Southeastern, at least for the 8.5 years, and I think it still is, right? Yeah.
We're still going strong. It's really well received. It's just unusual to be able to get to the first year students and give them a really fundamental understanding of what's CT, what is ultrasound, before you get to the pathology. It's just one of these topics in modern medicine. It's so important for the students to understand, and yet somehow it's ignored in modern medical curricula nationwide. But you have the vision to get it going and get us that course and let me lay the groundwork. So when I come back in the second year, we're talking about pathology and a VQ scan. They already know what nuclear medicine is. Now I can tell you about pulmonary embolism. So it's still going strong, and it was a great addition to the curriculum there.
And to this day, I'm so proud of the work that you're doing. Because when I talk to folks, and I talk about Nova Southeastern, when the topic comes up, the students, and I ask them, I'm like, well, do they know their stuff about radiology? And they say, the students are just incredible. They really know the radiology because you take them during the first year, give them the principles of radiology. During the second year, when they're in the systems course, you actually have them integrate the radiological learning, and they can actually read CTs, MRIs, chest X-rays, and everything when they even go out to third-year students, which is pretty remarkable. So, hats off to you and all the great work.
Thank you. And more importantly, they're familiar about the utilization patterns, right? So it's great that they can read the study, but for some of the high-end studies, they're never really going to have to read it in clinical practice. They need to know what to order, what not to order, contraindications, safety, and screening things. And mostly, what do you tell the patient? What's the patient experience going to be? How is it different in CT, MRI? What's nuclear medicine to begin with? So we're just finding that there's a gap really nationwide in many clinicians in their training. They just don't know about how to utilize these what's become a really complex set of tools in imaging and is at the forefront of diagnostic medicine. And so we're just trying to close those gaps earlier on for these students.
Yeah. Well, one of the things that always comes up with radiology, especially when we talk about the future of medicine, and especially with artificial intelligence and AI and all this other stuff, is there going to be a future for radiology? And so that's why I love this topic today. And we were kind of talking about the some of the changes that you've seen in your career with radiology. So, and you've seen pretty much all the most recent major changes. So
sure. Yeah, I always like to say that radiology. We may be the fastest moving field in all of medicine because it's really technology based, right? So at the speed that software, hardware, all these vendors trying to come out with the next greatest thing in imaging, we really move really quickly. You could be a dinosaur in 5 years in radiology if you're not keeping up. And for that matter, as a clinician utilizing this stuff, you have to know what are we offering now? What is the current state of the art? So you're not ordering an obsolete study that's been replaced by something better. In my career now, coming up on 25 years, there's been several what I would call revolutions or disruptive technologies in a good way that have just catapulted what we're able to do and continue to make impacts. So the first one really was when I was a resident. They transitioned in most parts of the country in the early 2000s from what we used to have called hard copy, and I always have to ask the students, do you know what film is? They've never seen a piece of film in any forum, and we were holding up X-rays to the light to read them, and CTs were being printed out, 20 little images on one sheet of film and 11 panels, and it was really unwieldy, and we transitioned to digital imaging and the so-called PACS system and reading things off monitors and scrolling with the mouse wheel, and it came just in time as radiology volumes and the dependence on imaging in modern medicine exploded. there's no way we could have handled this volume, one sheet of film at a time. And there's always a page missing, and the patient signed this one out, and the doctor had a different, study signed out. It was just very unwieldy and not as much fun, frankly, and not as, I don't think even as efficient and effective to read off of that. So that's the first big thing in my career.
And I love that, how you mentioned the word PACS. That was the thing 20 years ago. Everybody was talking about PACS and everything. It was really an acronym for PACS, or Picture Archive Computer System, I believe.
Yeah.
Is that what it was? And now you don't even think about that anymore because everything's digital.
That's the standard. Yeah, that's the standard. Yeah. And like I said, just in time, as we exploded into the new volume and the new era.
Yeah. And of course, the PACS system, the digital, radiological images really kind of open up the gateway for teleradiology, right? Yeah.
Right. So now you can see the images from everywhere. Now the images aren't lost. A patient comes in and the study opens up for me, and on the other monitor, automatically it opens the old study. So everything became just better for patient care. And yes, all of a sudden you could be seeing these images. You didn't have to be in the hospital where the patient was. These things could be read from somewhere else. So in our 6-hospital system, if we have our neuroradiology experts sitting in one hospital, they're reading the brain and spine MRIs with their subspecialty expertise from any of our hospitals, right? They don't have to be on site. So the subspecialty care got better, and then radiology practices were able to be more flexible in terms of their call schedule, their coverage, and some chose to outsource their overnight coverage, which made it easier for them to recruit, just telling new applicants, hey, at night we actually send this across the world, and someone will read it for you there. Our practice chose not to do that. We decided we wanted to keep everything in-house and vouch for our own quality, so we have our own internal night hawks among us who do the night shifts, but those are my partners. But that was a choice we made. But it was great for remote hospital systems who couldn't recruit a highly trained radiologist or subspecialist out to the middle of nowhere to be on site reading their films. Who's going to take care of those patients and read the images? And so they were able to outsource that through teleradiology systems, and that really revolutionized the care people were getting across the world, really, in real time.
Yeah. I'll never forget. You mentioned the word Nighthawk. I believe that was the name of the big company.
That was one of the first companies. Yeah. And no one knew where it was going to shake out, and where the legal implications, and where did the radiologists, what state did you have to be licensed in, and so that stuff follows. That whole technology and that whole industry has matured and stabilized, and offers, like I said, a lot of things for the radiology practices and for the hospital systems that they cover.
Yeah, I remember talking, 20 years ago to medical students, and they said, you don't want to go to radiology, and it was brilliant, right? At the time, and this was before telemedicine really took off in a lot of places, but you could literally be anywhere in the world, live where you want to live. If you want to live in Florida and you can practice, whatever, and it's great. Say for instance, you're that mom that has a different schedule, because your baby and stuff like that. You could really kind of pick the time that you want to do it, or work just nights, and of course the great thing about radiologists, heck, you're working out of your home office, and you can just wear shorts all day and stuff like that. Right?
I mean, where the impact of this teleradiology continued, and where we really found it at a new level was during COVID, and especially the pre-vaccine portion of that, where we were actually able to keep our workforce safe by quickly installing remote workstations. And that was, we were able to continue to provide care from remote areas, from remote stations, and read the studies in real time, and we got it done that way. And then what that led to for a lot of practices, including ours, who face rising volumes, and we want to recruit the best highly trained subspecialists into our practice. Remember, everyone in my practice does a 4-year residency after a PGY1 preliminary year of something else. Then when you do 4 years of radiology, you take the boards, you're board certified. But then everyone in my practice, really in the last 30 years that's been hired, did a PGY6 fellowship in one of the 6 or 7 subspecialties of radiology. So we try to give a higher level of care. And we want to recruit people of that level to continue to join our practice. And now with teleradiology, they don't have to move to South Florida if they don't want to, and they can read perfectly in real time and high quality from wherever they want to live. So with the next emerging workforce of radiologists, there's more flexibility than ever, especially on the diagnostic side. Obviously, interventional is really more in-house procedures. Obviously, you have to be where the patient is. But for the entire diagnostic part of it, this is new flexibility for a practice like mine to recruit the highest quality people, even if they don't want to be on site with us. You really wouldn't know in my practice who lives in South Florida and who doesn't. it just doesn't matter. They're reading, they're giving high quality interpretations from around the country now, the last few people we hired, and it's been a real benefit to us and our hospital system, our patients.
It's incredible, right?
Yeah.
And it's a way that technology really is transforming the way we practice medicine. And I would probably argue that, the speed of which, folks practice, heck, I remember, when I was in residency, we wanted to read on an X-ray or something like that. We physically had to carry it over to the radiologist, and we had to wait for him to finish up the last thing, and we're waiting out the door. And hey, can you do a quick read for me on whatever CT scan or whatever? And then they're going through, and I don't know. Sometimes the film got smudged or when it was going through or whatever, and then we had to rerun the whole study or whatever. It's a whole different world right now. Yeah.
Well, I'll tell you, one of the downsides of it was we actually don't have clinicians coming by the reading room anymore. And I remember as a medical student, one of the reasons I went into radiology was that every inpatient rotation that I was on, medicine, surgery, pediatrics, the inpatient side of OBGYN, every single day, at some point in the late morning, the senior resident would say, stop what you're doing. We were writing our notes, doing our scut work, and everybody go to the staircase. And then we'd, as a group, the whole team from the floor, barge in on the radiology reading room, and there were pairs of radiologists and their residents working at each station, and they'd ask us, who are you? Well, we're the medicine team from 5 North. All right, come over here. And then whoever on that team was the lowest on the totem pole, the third-year student, the intern, would give a quick bullet presentation. This is the admission from last night. Mrs. So-and-so, she came in with chest pain and shortness of breath. And then the radiologist would show us the admission chest x-ray, because that was the only copy of that x-ray, was a hard copy. You couldn't see it anywhere else. So in academics and medical schools, residencies, you got to go to the reading room if you want to see it. But what happened next is what's been lost. There was this an exchange, really, between the radiologist and the clinical team. So we'd say, oh, the chest x-rays look pretty good. How did she do overnight? And then they'd say, well, she's still desaturating. We think maybe she's had a PE. And then the radiologist would explain, well, you have 2 choices, CT chest with intravenous contrast with a specific protocol, or VQ scan. And then we would discuss why you would want to do one of those in this case or not. And the clinical team got some expertise. They got trained every day in radiology utilization. By the time these people were senior residents, they knew what to order because they had come and interacted every day on every patient with the radiologist. And the radiologists, we got clinical history that we wouldn't otherwise get, and we still often don't, which would give our better interpretations, better protocols. And I remember when I became a radiology resident, I would grab that intern on the way out and said, okay, you guys are going to get the PE study. Make sure she has a really good IV access because we have to inject the contrast faster for this. It's a CT angiogram. Don't send her to me with a 24-gauge butterfly in her thumb. It can't be done. Oh, great. The patient got the one best test every time. So that interaction has been lost. I have senior residents in our hospital from other clinical services. They don't know where the reading room is because they can be in any nursing station in the hospital, pull up the images. We're reading them fast. Voice recognition is another one, changed everything. In a couple of minutes, they have a finalized report with annotations, because when I put an arrow or I put a measurement, they can see that when I finalize the study. So in most doctors' minds, why would I go to the reading room? Everything has been served up here, but that interaction has been lost. So a lot of medical students don't consider radiology the way I did, because I was in there every day and I was like, this is really great. These guys know everything, and whatever we're throwing at them, they seem to know all this pathology, and they have the coolest toys in the hospital. And so I considered it as a career, and I made sure at first thing in 4th year, I did an elective and made sure that's really what I wanted. So that interaction is gone. But more importantly, I just don't find the opportunities the clinicians have anymore to interact with us, give us the clinical information, and learn about these really subtle and important utilization, principles, right? And here's the secret in clinical medicine that people don't realize. If you order the wrong study on a patient, and you can be off in a big way, it should have been a CT and you got an MRI, or it can be subtle. You got a CT, but you didn't get pre and post contrast images this time. The study will always be suboptimal, and in some cases, it's actually non-diagnostic and worthless. And that's the worst part of my day, right? Because I'm trying to help this patient, I'm trying to help you help this patient, and the study was doomed from the beginning because it wasn't the right study, because the clinician just never had this kind of training. That's what we're up against. I'm trying to close that gap, with educational efforts, because it's worth it.
Yeah. It's funny, you were talking about, the radiology reading room. I remember when I was a 3rd-year student, on internal medicine rounds, I'd have to go down to the reading room, and I'd have to take the list of our patients and put the films in order of all the films in the last 24 hours for every single patient, and tracking down, then they would be upside down in the wrong jacket and stuff. And
Oh,
then,
it was unwieldy. It was a mess, and then the patient hadn't been here for a while, so then what we used to call the jacket, right? Those huge folders of the X-rays would get taken to long-term storage, and how are we going to get those back? And yeah, it was messy, but the one benefit was that interaction. People had to come to the reading room, and now it's kind of lonely. They don't come by, and like you say, we may or may not even be there because people are reading off-site. So there's some unintended consequences to all of this, but we move forward with it.
Yeah, and I always remember you said, you would tell medical students, unless you go into, I think you said, unless you go into psychiatry, you're probably going to be, looking
sure.
at films, even radiologists or even dermatologists, look at, films, from time to time. But nowadays, I think the knowledge that the non-radiologist needs to have about radiology is greater than ever. Especially when they are looking at these things, because they pull up their own films and you can see it so easily in 2 seconds. You didn't have to walk down to some reading room, or if you're ambulatory, you can pull up every film on every patient instantaneously through the electronic health record. It really is. It's put, I think, more of a burden on education on the specialty of radiology than any other specialty in medicine, at least I think.
You got to know, you have to know how to interact with us. You have to know how to maximize, optimize these studies, or your patients are just not going to get the right care. And yes, more than ever, for better or for worse, diagnostic imaging has moved to the forefront of diagnosis, and that's where we're at. And so, why would we kind of tie our hands of the radiologist by not getting the exact right version of that study? There's so many sophisticated versions, and yet students are graduating programs, even residencies, without knowing what's a CT cystogram, what's a CT urogram, what's a CT colonoscopy. If you don't know that these cutting-edge studies exist and what the indications are, then you're never going to make use of them for your patients, and that's a unfortunate part of this. So yeah, every one of these people come out of training with very little exception, and on the first day of their practice, they're ordering several high-end imaging studies. You got to get the modality right, the body part, which is not trivial. You need that CT abdomen, pelvis, or abdomen and pelvis. I throw that out to some medical students, and there's pause. What's the difference? Where's the borderline? And then of course all of the contraindications. And I think it's sad when a patient shows up to an imaging center and they've been waiting for a couple weeks now because everybody's booked out for this appointment because they were told they had a spot on their lung and it could be cancer, and they're up all night and the doctor told them, don't worry, we'll get an MRI, we'll get to the bottom of this. Well, an MRI it's not that it's worse than CT for that indication, it's worth less. And that patient shows up to the imaging center, expecting a diagnosis, and now we're about to start a study which has zero chance of making that, for them. What are we supposed to do with that? It's not about me. I'm trying to help this patient, but should I proceed with that, knowing really ethically they're going to get charged for this, they're going to get in the magnet, they took a day off. If they have a problem in the magnet, they took some Valium, and they have a loved one who took their day off. It's a big event. An outpatient imaging study is a big event with a big cost. And if it's set up to fail because the clinician wasn't trained on actually getting the right test, that's unfortunate. That patient's going to get that study. It's going to be indeterminate, and it didn't have to be that way. And that's what we're trying to prevent.
Yeah. I can tell you over the years, the radiologists have been such a good, ally on patient care and stuff. Although, I will tell you, there's a little bit of PTSD, right? If all of a sudden, hey, doc, the radiologist wants to talk with you, it's never good. It's either I made a mistake on ordering something, which hopefully didn't happen too often, but it was more than likely something bad's going on with the patient.
Yeah, I mean, it is on us, and we've taken that responsibility to make sure we close the loop on any sort of either unexpected or critical results, and document that we have that conversation and make sure that the patient doesn't fall through the cracks. The patient may never come back to their ordering physician for those results. So yeah, we take that seriously about that. And we have so many studies to read. We may not call you with the good news, but it's interesting you bring it up because part of my educational efforts is also to explain to clinicians who haven't interacted with us, what is the good news? If I say calcified granuloma or hemangioma of the liver, you get to finally tell a patient, good news, that spot on your lung, your liver that we saw on the other x-ray or ultrasound, the radiologist said it's a completely benign finding. We never need to look at it again. And yet 6 months later, I'll see that patient follow up lung nodule for a completely benign finding. So people don't even understand necessarily the implications of our results when they're the good news, and we can't call you on all the good news findings. So that's part of the thing too, is for clinicians to understand, hey, what are the implications here? What do I need to do next? And there is a movement in radiology, in terms of future of radiology now, to standardize our reports, including the recommendations. So it's to really spell it out more for the clinicians. And you should be seeing that, I hope, in more and more of your reports. When something needs to be followed, we'll tell you and even give you a suggested interval for that. In the past, we didn't want to force your hands or tie your hands on any of these things, so we left it a little open-ended. But we're finding that the follow-up isn't exactly evidence-based, let's say, and so there's a movement to standardize, what we're recommending for incidental findings and otherwise, and put that in the reports and really serve it up. Don't forget, now patients have a portal, right? So that's also an unintended consequence, and patients, as soon as they leave the imaging center, I imagine they're on. We've all had family members or been imaged ourselves. It's all about what those results are, right? Nothing's going to happen in that patient's world until the CT is interpreted, and then someone acts on it, right? That's the next step. They're hanging on our every word, and they're on that portal, refreshing, waiting for that, and so we have to serve it up to the patients too, so that it may not be that their physician actually knows what to do with that finding because they just haven't been trained. So we're trying to put it in our reports now, and that's actually a current trend in standardized reporting.
Yeah, and I think also just how incredibly efficient radiology is, nowadays. So, up until about 2.5 years ago, I used to do shifts over at Advent Health, and of course, I love Advent Health. I love Orlando Health too. We have incredible healthcare systems here. But I remember one day I was doing a shift, and it was I think it was like Christmas Day, right? So I'm sitting there doing a shift at Christmas Day, admitting a patient in the emergency department. I was doing what they call the admissionist shifts, right? Or you just admit patients, and I admit 12, 14 patients, in a 12-hour period of time and stuff. So I'm sitting there and I'm going to see the patient. The patient had some neurological issues going on, so I sent for a stat CT, and the tech took the patient over, and I'm sitting there working on my note and stuff like that. I swear it was like less than 10 minutes later on Christmas Day. All of a sudden, I get this call on my cell phone from radiologist. It says, "Oh yeah, your patient." He said, "Your patient so and so, Mr. Smith or whatever." I looked over. He wasn't even in the room. He was still over in the CT scan. The tech hadn't brought him back yet, right? Yeah. And it was telling me about intracranial bleed, and just how incredibly efficient it was, and it was given, talking to doc, and of course the physician was, who knows where, right? It wasn't in the hospital, but just how efficient things were, and it's pretty remarkable where we are right now.
Yeah, look, I'm glad to hear that your local radiologists are providing that level of service. But what we're hearing around the country is that because of sort of the overkill, for lots of reasons why there's a lot of imaging, radiology practices are falling behind, outpatient, inpatients. And remember, the clock is ticking in different ways. An ER patient, we're being, literally, everything has a timestamp, right? So we're being clocked by the minute, and that's a metric we need to meet because that's an emergency patient. An inpatient, length of stay, right? An extra length of stay is a big deal to hospital administrators and patients and families. So that's running. And then an outpatient, we were used to the same day, next day service in this country, and it's starting to push its way out, mostly because just what I would honestly call an abuse of these resources by people, the clinicians just haven't been trained to make the most efficient. So you got that wrong study first, and then we have to recommend the right study, and now the patient gets 2 instead of 1, or people who still use what we call the shotgun approach, order 4 or 5 things and hope that one of them gives you the answer. So my prediction, and I tell the medical students, is that the rules are going to change. Nationwide, this is really stressed it to the limits. And we're hearing radiology practices, thankfully not us and not your radiologists, that have fallen way behind. In my years, we've doubled the number of radiologists from 30-something to almost 70 that we have in my practice to cover one hospital system. Wow. So we're able to keep up, but it's becoming more and more challenging to do so. And I think one of the only ways to do this, we can't just keep adding scanners and adding radiologists. It's going to have to be a re-education of going back to the old way. You got to examine that patient, come up with a differential diagnosis, come up with a working diagnosis, and be trained to understand what is the one best test for that scenario. And the American College of Radiology has tools for this, and they're just underutilized, and it's free, and you don't have to sign up, acr.org, and they're putting it out there for the clinicians, and it's user-friendly. And I lecture on this all the time, and people never saw it. So pull it up on your phone right now and keep it there the rest of your training. And every time you order an imaging study, see if that's what your attending's telling you to do. And don't be that student that second guesses your attending, but quietly start to form your own habits, because the rules, I think, are going to change. They're going to be they're going to be monitoring, what clinicians are doing. This emergency room physician and this one in the same ER with the same random, patients from the same population and the same acuity. Who's the overutilizer here? And why is that? Do you have any metrics to show you're doing a better job because you order 3 times the number of imaging studies? It's going to happen soon. This is my prediction, and we're really getting there.
Yeah. Yeah, and one of the things I think is also a little bit of a wild card in some of this discussion too is the point of care ultrasounds, the POCUS that we call it, right? That we actually train first year medical students, first month of medical school on how to use ultrasound probes, and we're actually and of course I'm going to get some of your advice today. We're actually kicking around the idea of giving every medical student their own POCUS machine, and what does that look like? So you have a non-radiologist, but that they're using ultrasound at bedside in real time. It goes back to, I remember, Eric Topol from the Scripps Institute 10 years ago said that, that in 10 years we won't even have stethoscopes. We're just going to use ultrasounds, there. So, it's interesting how that's also going to, you're going to hear more and more. The doc said, oh, well, on POCUS, I found this. So I want to get a CT or whatever, right? So.
Yeah, POCUS, my take on that, you would think as a radiologist I get all defensive about it. I actually welcome it. We have all the imaging that we can handle right now, and as long as the medical personnel is trained to perform the study, they have good equipment, everybody knows what they're doing, and it's good for the patient, let's go. I have no problem with this. It's just literally a matter of training. And what'll need to evolve is, what do you do with those images? Are those part of the PACS system? Do they get a dictation? Is it part of the medical record and the history and physical? That stuff will all shake out. But as long as people are trained to do it, know what they're doing, and like you say, the technology is there. You probably could give everybody. And it's amazing that we're still using the same exact stethoscope for like 100 years, right? Yeah. But I would like to see, don't ditch the stethoscope. Do your physical exam. You hear that systolic murmur, whatever. Now you can confirm it. Just do your own echo. I think it's going to be an extension of the physical exam, and then you just document that in your H&P. That's what I would love to see. I have no problem with that, as long as everybody knows what they're doing.
Yeah. Now, one of the things that, I wanted to kind of get your perspective on is, probably the topic I hear the most when we talk about, especially with AI and how AI is going to impact radiology. And I hear stuff like the sky's going to fall and they're not going to need radiologists in the future and stuff like that. I want to get your take on that.
Sure. It's a question I get a lot from my medical students, and especially the students that are in the radiology club at Nova and they're thinking about a career, So 10, 12 years ago, I just laughed it off, like, don't worry about it. It's not going to happen. And then 5 years ago, I'm like, let me think about this. Right now, what I'm seeing is that, and I think for the foreseeable future, AI has become really a wonderful kind of adjunct tool to the radiologist. And I'll tell you a little bit how we use it in our practice, and I think that's where it's going to continue to mature for the time being, as a second look for the radiologist, for one thing. So we have a product that when we first bought it for our practice, it was able to look for 2 very particular findings, I think, pneumothorax and intracranial bleed on a head CT. And that's the only algorithm it had, and it was helpful. Now, a few years later, there's 9 things that it's looking for, but on different scans. It can't read the whole scan. It can't know all of pathology and kind of match that up. But what it does is, I have, the volume is really challenging for radiologists, and I might have 3, 4, 5 stat studies at a time, and I just have a work list with names, medical record numbers, and in terms of clinical history, they all say pain. That's the history I'm given by the clinician. So I don't have a great way to triage that list, and they're all bright red in stat, because everything is stat, right? Even your outpatient with pulmonary fibrosis is stat. Yeah. So who do I read first? As this scan comes hot off the press, the robot, the AI, looks at it. And if it sees, in this case, it's actually pretty good now at looking for pulmonary embolism, it starts flashing that one as if to say to me, hey, doc, why don't you read this one first? And I love it, because who knows when I would have gotten to that study, right? It might have been a little bit of a delay till I just get to it if it's first come, first served. So, and I have to tell you that I've probably read 5,000 scans for PE with the robot, and it was, we differed on the diagnosis 4 times.
Wow, yeah. 4 out of 5,000?
Something like that. And wow. I was right all 4 times, just say.
Of course.
But I might differ 4 times with my partners too, right? So for inter-observer variability, that's not bad. But I'll take that. And in the 9th hour of my shift, when I've been full blast, because one of the things the students are amazed at is there's no downtime in a busy radiology practice. I'm very rarely caught up with nothing to do. So in that kind of shift where it's just coming in fast and hard for hours on end, in that 9th hour, I have found that the robot is not tired at all. Like, hey, here's another PE. What do you think of that? I'm like, and it picks up everything and for that diagnosis. And I think it'll just continue to mature for a while. I think on the order of years, where it's learning more and more how to pick up specific diagnoses, but can't integrate the whole case yet. And what I'm hearing from people in the industry on the vendor side is they don't expect necessarily a lot of these companies to even apply for the ability that these should be functioning with autonomous diagnosis without a radiologist supervision. They may really not want to take on the medical legal responsibility of that for quite some time, and we'll see. So at this point, my take is radiology in the near future, we need more right now human radiologists. Every practice in this country is hiring. And I think that will continue, for some time to make it worthwhile for students that are currently considering the field. And if you get to, a radiology residency, get on the AI committee in that hospital. They're always looking for residents to serve on hospital committees, and make yourself the expert on AI, because the next group coming out is going to be looked at by people in my practice kind of as, hey, what do you know about AI and how do we integrate this better? Can you bring us up to speed on that? So that's what you need to make an interest of yours while you're training, of course, in the rest of your radiology residency.
Yeah. And of course, nowadays you look around all the major health systems and they all have a chief of AI. And a lot of times it's usually a young career person that's the chief of AI. But again, it's a title that didn't get invented until like 3 years ago. But it's in some ways very similar to the chief medical informatics officer 15 years ago when EHRs came into base. So I agree with you. So it sounds like if you were graduating from medical school today, you would probably do the same thing.
I would do the same thing. Yeah, I would just keep my finger on this pulse, just like we did with teleradiology. We thought, there was this huge panic, everything's going to be outsourced, and they're not going to need diagnostic radiologists on site anymore, and the cheapest bidder gets it. And quality wins out, in a lot of cases, thankfully, and so it really never jeopardized it to that degree. And there was a lot of panic about that, I remember. But, my group has had the contract with our hospital system for twice as long as I've been there, and as long as we do quality work, I think it'll continue to be, hopefully stable for us too. So
yeah, well, we're so excited today at OCOM because Dr. Ditchek's actually going to be the first OCOM ground round speaker today, and I couldn't think of a better person to do it. What an incredible educator, radiologist, the GOAT, as I was telling one of the medical students before, really incredible. But, I wanted to talk a little bit about what you're doing and, in terms of, this personal, product that you're actually doing, and of course the medical students for years have always struggled how to learn radiology, especially if they didn't go to a place where Dr. Ditchek taught medical students. How do you learn radiology? It can be really tough. And right now, before what you're doing right now, there really has not been any decent, good board review material for medical students for radiology. So, if you could talk a little bit about that.
Yeah, thanks. I mean, first of all, it's great to be back. I had the honor last year of being the first guest lecturer in the history of OCOM, and that was very special. And I came and you gave me the VIP tour, and I just couldn't believe the facility and that you built here in Central Florida, and the staff and the faculty, and just an amazing institution. And I've been telling everybody. I mean, family, friends with college students thinking pre-med, I'm like, you got to get in here before this place is on the map. It's going to be hard to get into. Like, you got to think about it because it's really an amazing facility. So I couldn't wait to get back, and I'm glad that it's going to be grand rounds, today for that. So, but yeah, it's just this crazy gap in medical education, both on the institutional levels in medical school and even in the online world, where, as students turn to online products to fill in gaps, or their medical school may have not as optimal a situation. But my medical students at Nova, they like what I do, they like my style, and they've been asking me for years to kind of put something together. So coming out with an online course, and yeah, the first product of it will be really build towards board review, because students are concerned, especially about step 2 and shelf exams. And what they told me is that the modern medical student wants things efficient, tight, short videos, TikTok style. And so that's what I'm creating, a series of videos, really short, just a couple minutes each. You get in, get out, you learn one fact, and it takes you through everything you need to know. And you're going to get more points on the boards, but you're also going to know what you need to know as a clinician or a future radiologist, or someone just going to be involved in ordering studies for your patients. So the product is called This Is Rad. It's out now already, and I'm continuing to add content as we go. As we go, it's thisisradiology.com, and again, I just asked dozens or hundreds really of medical students over the years, how do you want this served up, and I'll try to meet exactly what you want.
Excellent. Well, I mean, we want to be an institutional subscription here at OCOM because I know your quality and and what you do and how you transform medical education from a radiological perspective for medical students. So I know that this is going to be an incredible thing that's potentially going to transform radiological education in America. So I'll tell you, Dr. Ditchek, it's been such a pleasure to have you on the podcast today, and really appreciate the time together. And of course, heck, I could probably talk all day, with you and pick your brain about these things. But thank you so much for being on our episode, and I look forward to collaborating in the years ahead.
Great, thank you. I really enjoyed it. Thank you.
Thank you. And again, this has been another episode of the OCOM podcast, Modern Medical Education. Please continue to join us each episode while we bring in incredible experts like this, that are really changing the future of medical education in America. So thank you for joining us once again.